So we also are trying to restrict it to live births, singleton, Florida residents, so we could track it, term, 37 weeks or more, no medical conditions prior to or during pregnancy, not medically indicated inductions, cesareans, not in labor. Labor was medically indicated if they were in labor, real labor, when they reported to triage, and for 37 or 38 weeks of gestation. Now, this slide we want to take a minute to just look at. So what did we achieve? You will see between January and December 2011 in those 6 hospitals, we lowered the induction rate, strong effect on a reduction of the cesarean rate, and we achieved less than 5% early elective inductions in those facilities. Not perfect, but change. Let me take you forward. We were blessed with a graduate student who was willing to go back to birth registry data that Florida had, looking carefully at the criteria for delivery. Although it may have imperfections, we divided Florida's deliveries for 5 years, and it's actually 6 years, into quintiles, and we established which facilities were in the highest quintile, which were in the lowest quintile. The red line shows our study intervention group of the voluntary 6 pilot hospitals. Couple of observations. One, you will notice that there is a trend in all the quintiles going downward over the years. That is probably effects of education and younger physicians entering into Florida's OB delivery. Maybe more than that. We haven't studied that and can't really tell you that, but there was change occurring. The red line shows how we dipped in those hospitals that were in the intervention group, and it enabled us to move forward with HEN hospitals, Health Engagement Network, in association with the State Hospital Association, in 16 hospitals starting in the fall of 2012. We are actively in that project using the model, albeit not as strict data abstraction, for a number of the reasons that happen in medical politics, medical economics, which you can ask me about, I guess. We provide a hospital fact sheet on request using birth certificate data together with disclaimers to any hospital that requests it as part of the population of getting them engaged. Most will tell you, we have no problem, we're doing just fine, until they look at this. Because at any moment in time, you're looking at one window, not continuum, with real data. So this has been very, very well accepted, and this project began with a graduate student. God bless graduate students, okay? Lessons learned. You gotta have a hospital policy. You have to have consensus scheduling guidelines. You have to be able to say no. You have to back up that no. You have to have an administration that says, oh, but that doctor does a lot of gynecologic surgery. If I'm tough on him, he'll move his patients somewhere else. I have some solutions for that. But we implemented hard stop process, empower the nurses and labor and delivery team support. Our unpublished preliminary data is exceptionally positive from labor and delivery room nurses and nursing administrators that this is a project. They've had wonderful support. They've been trying for years, and we're making progress. And you must have not covert administrative support, overt support. Administration of a hospital has to be involved and back it up.